Tokyo
Tokyo
Live
Live
Endoscopy
Endoscopy
1
1.
So hello everyone. Thank you very much for joining Tokyo Live Endoscopy 1. And today we have a very great session. The title is ESD for pharyngeal and esophageal neoplasia. So we have a very distinguished guest, two guests today, and two of them they worked very hard to develop the guideline or consensus meeting or some other. So it's my great honor to introduce two of them. So first, I would like to introduce the Dr. Katada Sensei. Katada Chikatoshi Sensei. So he is now the associate professor of Department of Gastroenterology, Kitasato University School of Medicine, Kanagawa, Japan. And he graduated from the Kitasato University, and in his career, he spent 4 years in the National Cancer Center, Tokyo, Japan. And as I mentioned, he is a great leader in the field of head and neck cancer diagnosis and treatment. Of course, he's mostly dedicated to head and neck and the esophagus and the stomach. The upper GI is his most specialist area. But today, I think he's focusing on to the pharyngeal region. So Dr. Katada, please.
Thank you for the opportunity of this lecture. Today's title is Pharyngeal transoral surgery. These are today's contents. Metacoronous head and neck cancer after endoscopic resection in patient with esophageal cancer. This is a study flow of the Japan esophageal cohort study, JEC study. We performed ESD for esophageal squamous cell carcinoma. Patients were enrolled after the procedure in this prospective cohort study. EGD was repeated every 6 months. Head and neck screening was repeated every 12 months. Grade C rugose voiding lesions increase the risk of metacoronous head and neck cancer. SIR of cancer according to the site in the study subject and the general population. SIR of the head and neck cancer is extremely high. This is a cumulative incidence rate of head and neck cancer after endoscopic resection. The major site of superficial head and neck cancer was hypopharynx. 2-year cumulative incidence rate was 3.7%. Summary. Grade C rugose voiding lesions markedly increase the risk of metacoronous head and neck cancer. The 2-year cumulative incidence rate of metacoronous cancer, head and neck cancer was 3.7%. The next content is endoscopic diagnosis for superficial head and neck cancer. This is a magnified view of superficial hypopharyngeal cancer in the left piriform sinus. Reddish area, brownish area, and scattered brown dots. So called, these are abnormal bases. Screening of oral cavity by NBI magnifying endoscopy can detect superficial oral cancer. NBI magnifying endoscopy is also useful for the detection of metacoronous superficial pharyngeal cancer occurring after chemoradiotherapy. According to Japan Endoscopy database, the head and neck were monitored at the time of screening in patients with esophageal cancer. White coat, keratosis, and abnormal microvessels are useful for the differential diagnosis of laryngeal regions. This slide is the Japan Esophageal Society classification. As you know, this is a classification of invasion depths based on vascular changes. The classification of type E vessels and AVA were related to small thickness of pharyngeal cancer. Summary. NBI magnifying endoscopy contributes the detection, differential diagnosis, and prediction of tumor thickness for superficial head and neck cancer. The final content is transoral surgery for superficial pharyngeal cancer. These are the procedures of transoral surgery for pharyngeal cancer. EMR and ESD were mainly performed by gastroenterologists. On the other hand, ELPS was mainly performed by head and neck surgeon using a long needle knife and long grasping forceps. This is a curved laryngoscope. An observation field of the pharynx can be secured by expanding the larynx under general anesthesia using a curved laryngoscope. The tip of the curved laryngoscope was positioned in the supraglottis, and access to the pharyngo-esophageal junction was achieved by lifting the larynx towards the anterior wall. This is a procedure of ELPS, endoscopic laryngopharyngeal surgery. This is a setting of ELPS. This is an endoscopist, and this is a head and neck surgeon. We can see the hypopharyngeal region using NBI, magnifying view, and iodine staining. We dissect the hypopharyngeal region, and we can get resected specimen and pathological diagnosis. This is a right reddish superficial cancer arising in the right cribriform sinus. Abnormal blast vessels can be seen on NBI magnifying endoscopy. Because the region was mainly associated with B1 blood vessels, the depth of tumor invasion was considered to be from the epithelium to the upper layer of the subepithelium. Differential diagnosis was lymphoid follicle. Pathological diagnosis of biopsy specimen was squamous cell carcinoma. After that, Rugol column endoscopy revealed a Rugol voiding region with a pink color sign. I'd like to show transoral surgery. This is endoscopic laryngopharyngeal surgery, ELPS. First, the endoscopist marked the region using a needle knife. Next, the endoscopist locally injected physiological saline solution using a local injection needle. Then a head and neck surgeon opened the surgical field using a long grasping forceps and start to perform entire circumferential resection using a long needle knife. The tip of a curved laryngoscope is moved from the supraglottis to the base of the tongue, allowing a working space to be secured. The entire circumferential resection is then completed. The endoscopists perform an additional local injection. The head and neck surgeon grasps the margin of a region using a grasping forceps and dissects the region with a needle knife. The tip of the curved laryngoscope is moved from the base of tongue to the supraglottis, thereby securing a distal working space. In this fashion, cooperative surgery performed by an endoscopist and a head and neck surgeon allows minimally invasive treatment with preservation of the larynx. Recently, we reported the result of National Multicenter Survey in Japan. This is a central pathological diagnostic criteria. The diagnostic criteria of invasion of squamous cell carcinoma are as follows. At least one solitary nest or intraepithelial carcinoma with a thickness of 500 micrometers. This is a study flow chart of the patients. 599 patients were enrolled in this survey. 568 patients were analyzed. The major factor leading to detection was before or after treatment of esophageal cancer. The major tumor location was hypopharynx. The major macroscopic type was flat region. The major treatment method in this survey was EMR or ESD. Envelope resection rate was 74%. Subepithelial invasion rate was 42.6%. Median treatment time was 48 minutes. Complication rate was 12.7%. Specific complications of head and neck region are as follows: laryngeal edema, subcutaneous emphysema, and aspiration pneumonia. Life-threatening complications rate was 0.5%. No treatment-related deaths. Temporary tracheotomy rate was 8.5%. The reasons for temporary tracheotomy are as follows: development of laryngeal edema, perioperative planned management, and difficulty for intraoperative bleeding management. The recurrence rate after transoral surgery are as follows. Local recurrence rate was 8.0%. Lymph node recurrence rate was 4.6%. and distant recurrence rate was 0.5%. Three-year overall survival rate was 88.1%. Subepital evasion is a poor prognostic factor for the recurrence. 3 years cause-specific survival rate were 99.6%, excellent. This is a RC curve analysis of tumor thickness and lymph node recurrence. The cutoff value was 1,000 micrometers. This slide is pathological predictive factors for lymph node recurrence, lymphatic infiltration, tumor thickness 1,000 micrometer or more, and lymph-C were predictive factor for lymph node recurrence in this survey. Summary. Transoral surgery for superficial head and neck cancer offers effective minimally invasive treatment. Future perspective. This is a phase 2-3 study of transoral surgery for superficial head and neck cancer in Japan, TOS-J trial. This is a study design of TOS-J trial. These are inclusion criteria. Superficial head and neck cancer of oropharynx, hypopharynx, and supraglottis. Squamous cell carcinoma, 4 centimeter or less, and N0M0. In phase 2 study, we will analyze the adverse events. In phase 3 study, we will analyze the endpoints. Primary endpoint in this study is 3-year overall survival. Registration was completed in August 2020. We will establish the indication of transoral surgery by TOS-J trial. Thank you for your attention, and thank you very much for our study group. Thank you very much.
So thank you very much, Katada Sensei. Great talk. And as he mentioned, so Katada Sensei actually organized lots of multi-center and RCT. And then last 10 years or 20 years, so he contributed greatly to this field. So he's of course the gastroenterologist, but he's also special. So you are the really a specialist of this area. And then, so now pharyngeal cancer also can be treated endoscopically, locally. So using the minimally invasive technique. So Dr. Philip Chu, would you give us some comments or question?
Thank you, Professor Inoue. So I think it's a really outstanding talk from Katada Sensei. So really nice to meet you, and also outstanding outcome reporting screening, use of image-enhanced endoscopy for pharyngeal and head and neck cancer, as well as treatment, and highlighted in this talk about ELPS and also ESD. So, and also to combine the technique with the head and neck surgeon and how to treat this early hypopharyngeal cancer by minimally invasive approach, preserving the larynx, which is very important for the quality of life for the patient. So congratulations to the great outcome, and also to have a future perspective of a prospective cohort study, which is really important. So I like to also ask about the future, because we know that it's really difficult to screen all people with such a lesion. But how about selecting those patients for surveillance kind of endoscopy to look for this lesion? So any idea or suggestions, so which group of patients should we select for screening or surveillance for looking for this early lesion?
Thank you very much. Screening of cancer in the head and neck region is not a common practice. However, early detection is important because advanced head and neck cancer has poor prognosis. Image-enhanced endoscopy such as NBI is revealed to be useful for early detection of head and neck cancer. We would like to emphasize the benefit of image-enhanced endoscopy in this field. We hope that it will be used in routine clinical practice. Screening for the high-risk patients is effective for the early detection of head and neck cancer. High-risk patients are as follows. Patients with esophageal squamous cell carcinoma, patients with head and neck cancer, heavy drinker, and smoker. Recently, laryngoscope has NBI system. It is very important that otolaryngologists know the potential of NBI laryngoscope, I think. Thank you very much.
Thank you so much. And also, I'd like to emphasize as a male, usually they have much more high risk. So maybe for the male healthcare perspective, also we should focus on the men who are heavy drinking and smoking. So maybe also easy facial flushing as well. Is it true?
Yes.
Thank you so much.
So yes, so nice discussion, and I also can I also have ask one question to Katada Sensei. So you mentioned that the one of the complications of ESD or ELPS, so laryngeal edema. So that is a very important and crucial complication we have to avoid. So do you suggest some prophylaxis to laryngeal edema right after or the day of the procedure?
Yeah, no, so most frequently adverse event was laryngeal edema. Yeah, and temporary tracheotomy was indicated in 8% in this survey. And so half of procedure were indicated for the planned tracheostomy to avoid airway obstruction. However, the indication for planned tracheostomy was not clear. Then we have to clear the definite indication of planned tracheostomy in the future. Recently, many surgeons don't perform the planned tracheostomy, so we must confirm the tracheotomy rate in the TOSE trial prospectively.
Thank you very much. That is a very important point. And so we ourselves doing place the mini track, so just in case. Yes, so place the just the it's a critical pharyngeal membrane tapping. So small track. It's originally developed right after the mostly esophageal surgery to suck the sputum out. So that is originally developed, and we also apply all the case. We do the ESD in the pharyngeal area. That is we keep the safe side. But so just the membrane puncture, it's a small incision and not so traumatic to the patient. So I think one of the choice.
Yeah. That is a great minimal invasive procedure, I think.
Yes.
Yeah, it's great.
Thank you so much. Yes, we agreement. So anyway, so thank you very much, Katada Sensei. We'd like to proceed to our next talk. Is the Yu Ishihara Sensei. He will talk about the ESD for superficial esophageal cancer. So I think no need to introduce him, but briefly, I would like to talk. So, Ryu Ishihara Sensei, he is a director of the Endoscopy Center, Department of Gastrointestinal Oncology, Osaka International Cancer Institute. He has also lots of original work and the papers published. So, Ishihara Sensei, please start your lecture.
Professor Inoue, thank you for the introduction. First of all, I'd like to thank Professor Inoue for giving me an opportunity to make presentation in such a good conference. Today, I will talk about endoscopic resection for superficial esophageal cancer. Endoscopic resection, ER, is a minimally invasive and potentially curative treatment for gastrointestinal cancers. There are two major methods of endoscopic resection for esophageal cancers, EMR and ESD. EMRC, which was developed by Professor Inoue about 30 years ago, realizes quick and complete removal of small esophageal cancers. For larger regions, ESD is mainly conducted. Before ESD, accurate preoperative diagnosis of cancer invasion depth is required. Non-magnifying endoscopy followed by magnifying endoscopy is a standard procedure in Japan. However, role of EUS is controversial. It is recommended in some guidelines and not recommended in other guidelines. We therefore conducted a multi-center study to confirm the usefulness of EUS. In this study, clinical MM-SM cancers were examined by non-magnifying endoscopy, magnifying endoscopy, and EUS. Additional effect of EUS was evaluated. Primary endpoint was overdiagnosis, which is pathological M or SM cancers, SM1 cancers diagnosed as clinical SM2 cancers, a proportion of these values, because overdiagnosis may cause overtreatment. In this study, 300 patients were registered and 269 patients were included in the final analysis. This slide shows primary endpoint overdiagnosis. Overdiagnosis increased in the main analysis and in all subgroups. Overall accuracy was similar before and after EUS. In summary, EUS did not improve accuracy and unfortunately increased overdiagnosis. So we do not recommend the additional routine use of EUS for diagnosing invasion depths of T1 esophageal cancers. Next, indication of endoscopic resection. Previous indication of endoscopic resection for esophageal SCC was EP-LPM cancers. Last year, the Japan Gastroenterological Endoscopy Society has published ESD-EMR guidelines. I was a member of the committee. In this guideline, adequacy of endoscopic resection for clinical MM-SM1 cancers was discussed. We first examined the diagnostic accuracy of magnifying endoscopy and EUS. And this table shows clinical diagnosis by magnifying endoscopy and pathologic diagnosis. Among 212 clinical MM-SM1 cancers, pathological MM-SM1 was 56%. And the important thing is 27% were pathological EP-LPM cancer. This is diagnostic accuracy of EUS. Among 58 clinical MMSM1 cancers, pathological MMSM1 was 29%. And the important thing is 55% were pathological EP-LPM cancer. The above results indicate that considerable discrepancy exists between clinical MMSM1 and pathological MMSM1 cancers. And even among clinical MMSM1 cancers, 27 to 55 of cases were pathological EP-LPM cancers, for which endoscopic resection is likely to be curative. So endoscopic resection should be selected as a first-line treatment in these cases. And we recommend endoscopic resection for clinical MMSM1 as well as clinical EP-LPM cancers. And this statement was supported by all guideline members. Next, I want to talk about process of ESD. This is the most popular method called letter C method. Mucosal incision and submucosal dissection of this part first, and then mucosal incision and submucosal dissection of the other part, and finally submucosal dissection of the central part. And now I will show a video. This is a case of esophageal cancer. We make mucosal incision of oral side like this, and then mucosal incision of left side, gently and carefully. And then submucosal dissection of left side, usually clearly observing some mucosa like this, and some mucosal dissection of oral part, and some mucosal dissection of middle part, and some mucosal dissection of anal part. And then mucosal incision and some mucosal dissection of right part, like this. Again, clearly observing some mucosa and coagulating vessel. And finally, some mucosal dissection of central part until total removal of the lesion. And I could complete some mucosal dissection. This is another method, tunnel method. This is a semi-circumferential region, and we decided to perform circumferential resection for this region. At first, mucosal incision of oral part and anal part, and deep cut of oral side is made until scope can dive into some mucosa like this. Then some mucosal tunnel is made like this, and some mucosal tunnel is widened. And now I can see anal side. And 2 or 3 tunnels are made in the same way. And finally, some mucosa between tunnels are dissected like this. And we could remove circumferential region like this. Clip with string is a very useful method which is used in most esophageal ESD in Japan. In this method, we prepare end clip attached to a string, hold the oral part mucosa by end clip, then release the tip of end clip. Another tip of the string leads to outside of the mouth. We gently pull the string this way. Now we can have countertraction of some mucosa, and the ESD process become much easier. endoscopic resection enables removal of large lesions, but may cause some complications. Common complications are these. First, I will talk about mediastinal emphysema. When air insufflation is used, mediastinal emphysema frequently occurs after ESD, even without perforation. Sometimes emphysema gets severe and may cause subcutaneous emphysema, laryngeal edema, and dyspnea. Carbon dioxide insufflation can totally eliminate the risk of severe mediastinal or subcutaneous emphysema. Even when severe muscular layer damage like this occurs during ESD, mediastinal emphysema remains quite mild if carbon dioxide is used. Next, about stricture. There are some methods to prevent stricture. The efficacy of preventive methods were reviewed in this article. These are preventive methods, and these are stricture rate for non-circumferential resection. When triamcinolone is used with small dose, the effect is not sufficient. But when triamcinolone is used with sufficient dose, 80 milligram or more, both of triamcinolone injection and oral steroid are effective for the prevention of stricture. For the prevention after circumferential resection, triamcinolone can prevent stricture, but for limited cases. Probably oral steroid has better preventive effect for circumferential resection. For comparison between local steroid injection and oral steroid, multi-center trial has been conducted in Japan, and the result will be released next year. Next, I want to talk about assessment of curability following endoscopic resection. In the guidelines, 2 clinical questions were evaluated regarding this point. First CQ is about additional treatment for pathologically diagnosed cancer without vascular invasion. I will show you the summary of metastasis rates in patients followed up without additional treatment after endoscopic resection. Overall metastasis rate of 5.6%. But I found some problems in these reports. Short observation period, implementation of immunostaining not described. We discussed about how to make recommendation, but final consensus was not achieved regarding additional treatment in patients with vascular invasion negative, because most studies were limited by short follow-up duration and insufficient histologic information. Probably we can make adequate recommendation in the future because we are currently conducting a prospective study for patients with pathological and SM1 cancers. We have already accumulated more than 300 pathological and SM1 cancers and following them now. Next CQ is about additional treatment for pathologically diagnosed SM cancers. This slide shows risk of metastasis in SM1 and SM2 vascular invasion negative and vascular invasion positive cancers. The rate is not reliable for SM2 and vascular invasion positive because the patient number is only 4, but overall, the metastasis risk is very high. By adding surgery, metastasis rate declines like this. By adding chemoradiotherapy, metastasis rate declines. But in patients with vascular invasion, metastasis rate is still high even after additional CRT. So we recommend additional treatment in patients with SM cancer. However, further investigation is needed regarding the type of additional treatment. We are planning to conduct retrospective study to compare surgery or CRT as the additional treatment after endoscopic resection. So let me sum up my talk today. Today, I talked about indication, resection methods, and curative ability of endoscopic resection for esophageal SCC. I hope my talk today contribute to your future practice. Thank you for your attention.
So thank you very much, Ishihara Sensei. Your great presentation of the lecture. And so he covers the starting from the diagnosis and the also the treatment mostly based upon the guideline. So he organized. So Dr. Philip Chu, would you mind to comment this great lecture?
Yes, thank you so much, Professor Inoue, and congratulations to Ishihara Sensei. And this is really wonderful summary of I think actually addressing a lot of controversial issue with current guidelines and evidence, including the application of US, showing that in fact it doesn't actually recommend for staging procedure, and also the indication for endoscopic resection, especially for those who are not too sure the depth of the invasion, whether it's a MM or SM1, then still we can actually do ESD. I think I consider that as a diagnostic ESD, and subsequently to consider whether additional treatment should be provided. And also different methods of ESD procedure, I would say is ESD make easy for esophagus, which is always considered to be really difficult. And you mentioned about letter C method, tunnel method, and clip and string method, which are really, really practical. And then afterwards, the whether we should provide additional treatment. And this is in fact really important and a lot of argument. And especially when we know that comparing to ESD, surgery like esophagectomy have a significantly higher risk and also imposing a lot of poorer quality of life as compared to preservation of the esophagus. So I think we are eagerly awaiting the results, especially in terms of whether we should provide additional treatment by chemo-RT or surgery for patients who are non-curative SM1 invasion. And so I think we are looking forward to this trial. So really, really a great lecture. And I have one question, especially about the performance of esophageal ESD. Nowadays, I think a lot of, like previous lecture also discussed about the elderly population. So I know that yeah, in Japan and also in Hong Kong, we are seeing a lot of elderly population. So we know that the elderly is a limitation to esophagectomy. But how about if there's any suspicious of a non-curative but not too sure, would you provide ESD for treatment of this early esophageal neoplasia for elderly like more than 80 years old?
I see. That is a quite important question. Actually, I usually perform ESD for such patients. But last week, I was discussing with doctors in NCC or in NCCE, and they said for elderly patient, 80 years old or older, they usually perform radiation. And I asked them, why do you perform radiation? Maybe endoscopic resection is less invasive and suitable for the treatment of elderly patients. So in my opinion, I usually perform ESD for patients older than 80 years old.
Thank you very much. I fully agree with you.
Yeah, I also agree with Ishihara Sensei's comment. So particularly older generation, the surgery is extremely invasive. So pharynxes as well. So surgery itself, in this area, pharyngeal esophageal region, the surgery is a quite big surgery compared to gastrectomy or colectomy. It's a so particularly colectomy is non-invasive, not so much. Even we resect the wide area, but so esophagus, we have to perform some thoracic approach, and so we have to make a very high anastomosis with the stomach or some other. So anyway, so very high potential risk of complication. So yes. So that is the background. So the patient who had the SM1 with the vessel invasion, and also SM2 and more patient, the clinically N0. In such a case, so we have to think more and more local resection. So Philip and myself, so originally esophageal surgeon, so but we know the endoscopic treatment. So it's a less invasive treatment, sometimes least invasive treatment for the cancer patients. Most of the surgeons do not recognize well about endoscopic treatment, but two of us, some exception. So we understand very well. So Philip, would you comment something about it?
Yeah, I think so. So actually, when we are doing esophagectomy, nowadays we also adopt minimal invasive approach. So meaning totally, small incision for thoracoscopic, laparoscopic, and the biggest incision is over the neck. But still, patients have a lot of, complication, which sometimes is out of our control. While we are comparing with the endoscopic resection, I think the quality of life and also the improvement, survival is everything much better than the surgery. So I would, of course, agree with the two renowned speakers. We should, in fact, do more, focus more on endoscopic diagnosis and treatment. So detection becomes very important in these early lesions. So how do we select patients who should be adopted this screening or surveillance endoscopy? I know in Japan you have a screening program, but in other country we don't have a screening program. But doesn't mean that we cannot detect this lesion, because the current use of the image enhanced endoscopy like NBI, they are in fact helping. But the less endoscopies are adopting such a procedure. So would you, also I'd like to ask the comment whether a routine image enhanced endoscopy like NBI or now even with the TXI should be used during the endoscopic examination for the esophagus?
Yeah. So Ishihara Sensei, would you comment something about it?
Yes, of course. I really think that NBI or BLI should be used for the screening of the esophagus. But when I was talking with some clinicians in Japan, they sometimes say they don't have NBI or BLI system. So maybe in the world, many endoscopists do not have NBI or BLI. For such endoscopists, white light image is still important. But for endoscopists who have NBI or BLI, I think we should use these technologies for the screening of esophageal lesions.
So thank you very much, Ishihara Sensei. And I also, would you also comment on the AI diagnosis? He's a researcher of AI diagnosis in esophageal cancer.
Yes. We are currently conducting the research for AI. And AI has big potential to improve the detection of esophageal cancer. But development of AI is not so easy. We sent a lot of data, but the company still says, please wait. There are too many data. And usually they want to develop gastric AI because there is much more demand for gastric AI than esophageal AI. So maybe next 1 year or 2 years, we can develop good esophageal AI. But we have to still wait for the development of AI system.
Thank you. So Philip, would you comment on AI?
Yeah, I think there are a few layers of AI development nowadays. So AI may be enhancing the standardization of examination, firstly. Secondly is the detection. Third is characterization. So I hope that this layer could actually enhance the detection of this early lesion. And so I agree that we are also working with some company, and they are also have a lot of difficulty managing the data. And also our clinician, it's also difficult because we need to annotate all the pictures and also to tell the engineer. But this is an important development. I believe nowadays, even the standardization of procedure, like a complete examination of the whole upper GI tract using AI-driven protocol should be adopted.
So thank you very much. So time is coming. So we once again appreciate the great two speakers and the Philip. Thank you very much for your great comments. And the once again in this area, pharynx and the esophagus is I remember very well when I was a resident. Even the squamous cell carcinoma mucosa receives the esophagectomy. So because at the time, so when we found the region, anyway, took a biopsy, and squamous cell carcinoma proven. Then so send the patient to surgery, and the patient receives a big surgery. So it was yes, very old days. But nowadays we can detect the mucosal cancer and the early stage cancer, and then we perform the endoscopic treatment for it. So marked advancement, and the it's extended to pharynx, starting from the esophagus, and then nowadays extended it to the same concept to pharynx. So so patient yes, benefit becomes larger and larger, I believe. So two of the speakers. So both of you conducted lots of nation-wide study. So please continue and bring the lots of benefit to our patients. And once again, thank you very much, Philip, too, your wonderful comments, nice comments. So thank you very much, everybody, and have a nice day.
Thank you.
Much.